March has been a busy month. We had a day, shuffle day, and also the Easter weekend, the previous weekend. So we didn't have any presentations, but we are glad to be back once more to continue with our webinar presentations and helping colleagues collect their CPD points. And I see that there are many colleagues who are struggling to get CPD points, and we are availing this platform free at no cost to you. So please do join us every week, and also encourage other colleagues to join us at this platform. And so this is brought to you weekly by Clinix Health Group, and we just want to thank management for allowing us to do this weekly webinars on a week, this webinars since we started 3 years ago, and you've been coming in large numbers. And we appreciate that. And note that these are CPD accredited webinars, and also we're doing them, we stream live on YouTube. So at any time when you wish to go back and watch the video, you'll be able to do so at your leisure. We're also looking at the possibilities of getting this, those who are not able to join us live, to be able to go to the YouTube and watch them and get CPD points. It's something that we are exploring going into the future. So we just want to thank you for that. And let's mute Mr. Dr. Mmusakgotla. And this evening we are excited to be bringing to you someone who's well known to Clinix Health Group, Dr. Mmusakgotla Modise, who's working at Clinix Health Group as a diagnostic and interventional radiologist. He is a partner director at Drs. Mashau and Chikau Incorporated, practicing at all the 4 Clinix Health Group hospitals, and acute hospitals, and one day hospital in Gauteng. And Dr. Modise is also a member of the SAINS, or the South African Interventional Radiology Society. He obtained his Bachelor of Medicine, Bachelor of Surgery in 2005 from the University of Pretoria. And he further completed his Master's Med in Diagnostic Radiology in 2016 from Sefako Health Sciences University, SMU, and completed his Peripheral Embolization Training Certificate in Turkey at the Sakura City Hospital. It's not in 2003, obviously, because that would have been long before he qualified as a medical doctor. We will correct that. It's later on, after 2016, when he was already a specialist in radiology. And so this evening, we're excited to have him to speak to us on something that he's passionate about. He does embolization at the hospital, uterine embolization. He spoke about it earlier, sometime last year. So today is going to be speaking about the catheter-directed thrombolysis for severe pulmonary embolism and also DVT, deep vein thrombosis. So excited to have you here, Dr. Modise. And he tells me that there'll be a 2-part presentation. He'll do the clinical part, and there'll be someone who works with him, the technical side, to do the presentation on utilization of the equipment that he uses for some of the procedures that he does at our hospitals. So welcome, Dr. Modise. We are happy to have you with us this evening to talk to colleagues and all of us who are here. Thank you.
Thank you very much, Dr. Bila, for the introduction. Can I share my screen now?
Sure.
Thank you, and thank everyone for taking the opportunity to listen to me today for this wonderful presentation about the latest development in management of pulmonary embolism and DVT. I have a colleague from Boston Scientific, Francois. He'll join, he'll do the technical part of the presentation in the last 15 minutes of the presentation. So I'm just gonna do the clinical overview of this interesting topic, and in terms of the latest developments and what we have achieved, or what are the developments that have made us to be able to manage this common pathology easily. So just starting up with my slides. So the main focus is predominantly on pulmonary embolism and deep venous thrombosis. So just to give a bit of background for everyone to be able to catch up with what I'm talking about. I'm not sure if the video is off because seems to be audio only. Earlier the video was connected. Kamkhelo, can I continue without video? Can I continue without video? It seems to be off now.
No, it's I just gave you privileges, so you can turn the iPad on.
Okay. Okay, it's on. Should I continue because it seems like the video is not working?
Okay, no, it's fine, Doc. You can continue.
Okay, just introduction for everyone. So today we're discussing pulmonary embolism. I just want to give a bit of background in terms of the commonness or how the incidence of the disease that we're talking about. So pulmonary embolism, as known as PE, is the third most common life-threatening acute cardiovascular syndrome that we're all aware of. It has a considerable effect in terms of management of patients in the hospital, mortality and morbidity around the world. Over decades, the other diseases like myocardial infarction and the ischemic stroke has got attention in terms of development in treatment of this condition, but there was less being done in terms of management of pulmonary embolism. So lately, over the past few years, there have been discoveries of other method of managing this disease, which is what brought us to this discussion today. One of the options is what we call catheter-directed PE treatment, which has actually closed the gap, and there are different kinds of catheters in the market at the moment that has been studied and explored in terms of management of this patient. So as I say, in the market now, there are multiple catheters, but today we'll just be focused on one that we use in our facility. So these catheters are used to remove the thrombotic materials from the pulmonary arteries and their branches quickly, effectively, and safely, and assisting the patient to develop a good perfusion to the lung parenchyma. So it is reported that early pulmonary death risk in high-risk patient exceeds more than 50%, according to the cohort studies. And these patients happens to lose their life in the first few hours of admission. So systemic thrombolysis, as documented in the literature, remains the preferred lines of treatment for these high-risk patients. But we know that with systemic thrombolysis, these patients are prone, more than 50% of them are prone to have high risk of bleeding post-admission or during admission of this systemic thrombolysis treatment. And there's a huge trial, which is a worldwide trial called Pieto trial, which showed that the 5% of these patients who are given anticoagulant suffers hemodynamic decompensation or die within the first 72 hours after admission in commonly normotensive patients or the patients that don't have hemodynamic compromise. So the risk factors for PE or DVT, as we all know, includes elderly patients, patients with high BMI, immobile patients, patients who smoke or who been pregnant recently, patient who has undergone a major surgery and are immobile in ward or in ICU bed, patient with known cancer who have received treatment like radiation or chemotherapy, patient with chronic pulmonary disease, patient with CVA, cardiovascular patient, or patient with inflammatory bowel disease. And the clinical presentation, this patient presents with sudden dyspnea, tachypnea. Some of them can present with coughing or respiratory distress. Some patients present with hemoptysis. Patients present with fever, and some will have leg pain or swelling secondary to development of deep venous thrombosis. These patients can also present with upper abdominal pains or pulmonary infarct. So what we need to address, which is the main discussion here, is what the challenges that these doctors are treating this patient are faced with. Firstly, we need to make sure that the knowledge and the evidence of the clinical effectiveness of many available systems we're well aware of have good knowledge when it comes to that. And we need to answer the question whether these systems has clinically proven to be superior to the standard treatment, in brackets, standard treatment meaning anticoagulants or systemic thrombolysis. And we need to find out what are the gaps in this available system, multiple system that we have, and which studies are carried out to close the gaps that we experience. And we have to also answer the question, how should the multidisciplinary response team, which I'll discuss, which is the most important part of our discussion, be structured in a way to be able to manage this acute situation of this patient? And what are the standardized processes that the PET group or the response team should use for decisions and action in terms of management of this patient? So generally, globally, there is what we call risk-adapted management. So this risk-adapted management help us to diagnose, treat this PE patient with risk management approach algorithm to ensure the structured approach. And this approach ensures standardized patient selection, standardized timing of treatment, and standardized technique for the procedure to undertake for treat this patient. So the individualized risk determines the treatment options for reperfusion therapy for this patient. The options include intravenous thrombolysis, catheter-directed thrombolysis, or surgical embolectomy. Or some patients undergo pharmacomechanical circulatory support, or patient with minimal risk are only put on anticoagulants. So the main important point is that individual risk of this patient determines the treatment option, and that will definitely be decided by the treatment or by the response team. So this is a comprehensive sort of algorithm which is being used globally, and different groups have developed or modified this approach to suit their environment. So basically, all these patients that come with acute pulmonary embolism into the emergency department, they all receive initial anticoagulants based on the clinical or positive clinical symptoms that suggest that they've got pulmonary embolism. So in terms of algorithm or structured approach to this treatment, you need to categorize patient on the risk as presented clinically. So those patients that are low risk, they will only receive anticoagulants. And we have what we call intermediate high risk, or the other definition is submassive group or high risk group. So the high risk group present with hemodynamic decompensation, or the patient will have a history of collapse at home. The intermediate group are normotensive patients, or like clinically stable patient. And those patients, then they give us time to actually do all those investigations to decide whether they fall on, they require immediate treatment, or they can just be treated with anticoagulants. So if you look at my diagram, there are those circles there of different colors, the central reporting office. So central reporting office is making up of what you call the PET team. PET team has all those specialties which are grouped together in terms of discussing and managing this patient. So the intermediate group are investigated with those, are going to details of those investigations of the intermediate group. And there is what you call new risk stratification as well, which determines the risk of bleeding of this patient. So those patients with a low risk of bleeding, you can treat them with intravenous thrombolysis. And the ones with intermediate risk of bleeding, you can use CDT, which is catheter-directed thrombolysis. Or higher risk is catheter-directed embolectomy or surgical thrombectomy, which is STE at the bottom. So this is a comprehensive sort of schematic representation of management of this patient in terms of approach, in terms of steps of the treating doctors to take to enable that the patient receive a good treatment. So this is an example of one that we have developed in our setting here at Lesedi. So because most of the time these patients come into casualty or they are seen in ICU. So the first study that we do is what we call CTPA, which is which is coronary pulmonary angiogram. So with coronary pulmonary angiogram, what we look for the thrombi. I'll show an example image, schematic image representing that. So we look for the thrombus in the main vessels, which we call a thrombus burden. So if the patient has, so patients, you divide them into two. So it's massive and non-massive. The one, what you call massive one, which is the high risk one. So they will have these two groups of patients, both of them will have thrombi in the main pulmonary vessels, but the massive PE1 or high risk PE1, you will also use the clinical assessment of this patient to categorize them. So these ones, they come in shock, they'll have low BP, they'll require resuscitation. So this one will require the team to make a fast track decision and push the patient to either, depending on the risk of bleeding, to choose those categories at the bottom there. So the patient that are hemodynamically stable, the one with normal vitals, it gives us an opportunity to do other studies. So you look at cardiac markers like TROP-T and BPN, because with this other markers being positive, then it highlights that the patient is in risk, it requires treatment immediately. So what we look for on when we do CT imaging is to look at the right ventricular strain. With right ventricular strain, I'll show you the diagram now. You look at the ratio between right ventricle and left ventricle. So you look at the ratio. If it's more than 0.9 with CTPA, we know that the patient is at risk, will require treatment. If there is no right ventricular strain, you can continue and categorize the patient as low risk and just give normal anticoagulants. If there's signs of right ventricular strain with positive cardiac markers, in our setting, we have also included cardiac echo to make sure that we measure the pulmonary arterial pressures as well, and to confirm the right ventricular dysfunction on echoes supplementing the CTPA. So based on the risk of bleeding, then the patient is either receive different options. At the moment, what we do at LESED is to put this patient, take them to cath lab and do what we call catheter directed, the ecosystem, which my colleague from Boston will discuss in detail in the last part of the discussion. So what are the contraindications in terms of general approach to this patient? So we know that there are those patients that they have absolute contraindication. So patients that have recent hemorrhagic stroke, we can do thrombolysis for them, either catheter directed or IV thrombolysis. Patient who had ischemic stroke in the past 6 months, they are not candidates as well. Patient with neoplasm, we don't thrombolyze this patient because they are at high risk of bleeding. Patient who had major trauma or major surgical intervention or head injury in the previous 3 weeks, they are contraindicated. Patient who had bleeding or coagulopathy, we don't consider them for thrombolysis as well. Patient with active bleeding, they are contraindicated for consideration of this treatment. So there are relative ones which are listed there, which you can have a look if you are interested. And so in terms of categorization of this patient, like I said, they are what you call high risk or medium risk or intermediate high risk, or in our terminology, we say massive PE. So these patients will come in our casualty setting requiring resuscitation, or patient will have obstructive shock with low BP, requires treatment in casualty setting. This patient will present with end organ hypotension, like listed there. And so those are the three main things. They present with cardiac arrest, the obstructive shock, or persistent hypotension more than 15 minutes. These are the patient that the response team has to make an immediate call in terms of taking them for treatment as soon as possible. So this is the intermediate or submassive high-risk patient. So these are the list of investigation, like I showed you in that algorithm in terms of what investigation we need to do. We look at the heart rate. We look clinically, those are the parameters that we look at. We look at the heart rate of the patient. If the patient has tachycardia of over 100, it's a candidate. If the patient has tachypnea as well, low set, oxygen dependent, So we do what we call cardiac echo and CTPA. Like I said, in our setting, the readily available investigation. Most of all these patients, the clinicians refer them for CTPA in radiology department, and we tend to do them as quickly as possible. So in terms of suspicion or grouping our patient as intermediate, we also do a cardiac echo and look at the IVC to see if there's congestion there and look at the pulmonary pressures. So the laboratory investigations that we do for this patient, we take the cardiac markers, TROP-T and pro-BNP, and we can also do serum lactate because elevation of these markers will give the sign of right cardiac strain. So like I mentioned, so in terms of this is a CT image. So when we do the CTPA for these patients, we also interested in the right ventricular function. So this is how we measure the right ventricular and the left ventricular function. So if the ratio is 0.9, then patient is a candidate or is classified as intermediate high-risk patient. Just for the benefit of everyone, the schematic diagram on the left side of the image is what looks like the filling defect, or if you look at the image at the top left corner, it is the main pulmonary artery there with the right and the left branch and what we call hypodense filling defect there. You can see it crossing over between the left and the right. So this is how acute PE or with thrombus burden looks like. You can actually see at the bottom image there's filling defects, there's contrast, and then there's a filling defect on the interlobar arteries bilaterally depicted by the arrows on the left bottom corner there. So these are the images that represent acute pulmonary embolism. But for a radiologist, it's important to differentiate between acute and chronic pulmonary embolism. So all those images, the 6 images on the right side represented the different signs of chronic pulmonary embolism, which is for us radiologists to be able to differentiate. I was just showing that I wanted to show the diagram that shows the difference between the two. So the left 2 images are the acute and the rest of the images are the signs of chronic pulmonary embolism. So in terms of patient being ICU and for the team, the response team to decide whether the patient is a candidate for immediate treatment or patient can wait for 4 to 5 hours, there's a national early warning sign score that is developed that is used in Europe in most of the centers, where they look at the clinical imaging, the clinical presentation of the patient. So this chart can be used by the sisters to actually score the patient like regularly with throughout the monitoring of the patient in ICU or high care setting, whereby then they give us a score regularly, let's say in 30 minutes or on an hourly basis. So we know that the higher the score, then the patients needs to come through for immediate intervention. Or if the score is around 5, then patients can be followed up closely and reevaluate again in a closer time space, and for the monitoring personnel to be able to caution the response team. So we look at respiratory rate, saturation, the temperature of the patient, the BP of the patient, the heart rate, and the level of consciousness. So that's a good schematic diagram in terms of monitoring of this patient when they are admitted in the hospital to decide whether the patient required close or continuous monitoring, or the patient is treated as an emergency. So like I mentioned earlier, if you look at that schematic diagram that I showed, two of them, the most important component of management of this patient is for the center to develop what you call a PET team. So PE response team is a multidisciplinary team that is set up in every setting to be able to make decisions on how to manage this patient. So currently there are international guidelines that recommends that the PE team discuss the intermediate. So basically, as soon as there's a confirmation of PE, the patient is then categorized as high risk or intermediate high risk, or the language that we use locally, say massive or submassive category. So the PE team responsibility is to make the decision in terms of management of the high and intermediate risk patients. So it is important to highlight that the PET team should compose specialists with different practical experience. Like I showed in the initial schematic diagram, there is involvement. I mean, in our city, we have interventional radiologists as a member, interventional cardiologist as a member of the team. We've got anesthetist personnel, we've got ICU personnel in terms of management of this patient. We've got a cardiothoracic in the team as well. So the team the team complement is based on the local circumstances and the resources. So the idea of having this optimal of this PET team is because some of the patients will require discussion and in terms of management of the specific patient, and different members of the team, it gives an opportunity for the patient to get optimal management because of the discussion from the members of the team. So optimal management strategy in this patient is mostly based on the knowledge of the team members of specialists rather than the evidence alone. So the protocols are developed by the PET team, which is accessible to all the personnel in the hospital. The personnel in the hospital from casualty to ICU will know exactly who to call and how to activate the pathway. So there should be a set pathway in terms of an operation mode, in terms of who to call when you have a patient, intermediate of high-risk patient, and start protocol on how to go about it. So it's important that the PET has a coordinator who's always available, which is not practical, but the PE has to have like a call roster or call system whereby everyone in the ground will know who to call and when to call them. So the last point of development or structure of a PET team is that it's important for the task team to support all the clinical decision, because sometimes you'll find that there's disagreement in terms of how to manage this patient, but it's important for all team members to have a common, at the end of a discussion of management of patient, for everyone to be supportive of the final decision taken. So just a brief overview of the main topic or the catheter-directed treatment of this patient. So there are various techniques which I'll show the list of and the system that are available. And there's a lot of research being done around the world about different catheters and how they work. But we know that at the moment there's sort of lack of large randomized data that can actually point to a system of recommendation to use in turn. And also there's still a lot of research in terms of how to select optimal selection of patient with a specific system or technique. But the most important thing is the aim of this directed treatment is to preserve or reintroduce reperfusion so that the patient can stabilize hemodynamically. So the purpose is not completely to resolve the clot, but rather than to improve hemodynamic image of the patient by reperfusion. So the purpose is not to completely remove the burden of the clot, but to improve the hemodynamic state of the patient. During this procedure, the patients are continuously monitored, or what happens is that post the insertion of this catheters, patients are taken back to ICU for continuous monitoring. So we monitor the vitals, and the aim is to get reperfusion target of this patient so that there's hemodynamic stability. When there's hemodynamic stability, the catheters can then be removed. So specifically with the catheters that we're using from Boston Scientific called ECHOS, the suggested time of running of this is between 6 to 24 hours. But we know that the longer you keep the patient in the treatment, you increase the risk of bleeding. And so the shorter the treatment is, the more the patient will benefit, because the aim is not to completely remove the thrombus burden, like I mentioned, but to achieve hemodynamic stability. So the indication for this catheter-directed treatment includes contraindication for systemic thrombolysis, high-risk patients, failure of systemic thrombolysis. We know it's very subjective when we say failure. Does failure mean if the patient did not respond? With the articles that I went through, they say that you expect patients with high risk to have a good response within 4 hours post-treatment, but it's also subjective. So it depends on the clinical image of the patient, whether the systemic thrombolysis have failed. And for intermediate risk is when patients have been given anticoagulants as well, with no improvement over a period of time, or patient with contraindicated systemic thrombolysis, then this patient can be done catheter-directed treatment, or the patient that have failure of systemic thrombolysis as well. So these are the basic indication for catheter-directed treatment. I'm just giving a schematic representation of all the catheters that are available at the market, in the market at the moment. So we have what we call catheter-directed thrombolysis category, and catheter-directed thrombectomy or fragmentation or aspiration at the moment in the market. And for the purpose of this discussion, our interest is in the echosonic catheter-directed, the third one in the list, which is ultrasound-assisted thrombolysis. And my colleague from Boston Scientific will give us the physics behind and the functioning of this catheter. It's a 5 French catheter. And with I know most of these catheters, the thrombectomy catheters or fragmentation, they are not available in our setting. I know Boston Scientific has this angiojet, but it has reported complication in terms of pulmonary artery usage. There's a new, the Indico Penumbra one, I know is coming to the country. It's a one that is well researched now at the moment, and it's been neutralized in Europe and America as a good candidate to do thrombectomy, catheter-directed thrombectomy. That's the end of my presentation. They're just references that I've used. I just wanted to check if my Francois is around to do the second part of the presentation. Thank you. Hello.
Hi, Doc.
Yeah, I think if you can allow Francois to
Connect,
unmute
please.
into- Yeah.
Yes, he can unmute here.
Francois,
Good evening, all. I just want to confirm, can you all hear me?
Yeah, sure. We
Yes,
can.
sure.
Good evening. I just want to take the opportunity to thank everybody, especially Clinix Group, Dr. Modise, for the opportunity. My name is Francois van Staden. I'm an account manager for Boston Scientific, working in the Pretoria region. And I've had quite the privilege of having quite a good experience with ECOS, that we have done quite a majority or quite a few cases. I just want to make sure that I share the correct presentation. There we go. Just want to confirm everybody can see the presentation currently.
Yes, we can.
Yeah, sure. We can see it. Yeah, sure.
So I'm going to speak on the ECOS device. It stands for Echosonic Endovascular Device. As Dr. Modise did discuss, there's just a disclaimer from Boston Scientific regarding the catheters. I'm not going to spend a lot of details. So firstly, I'm just going to start off with saying it's a very minimally invasive procedure. It usually gets done either in cath lab or in a hybrid under fluoroscopic imaging. On the left and in the middle, everybody can see there's an animation of the placement of the catheters, and on the right, that is a fluoroscopic image of a bilateral pulmonary ECOS placement for the treatment of pulmonary embolisms. So usually the access sites, you can use jugular vein, cephalic vein, or then femoral vein. It all depends on the patient and the accessibility to the SVC or IVC. The catheter will go up the inferior vena cava, through the right heart, and into the pulmonary arteries and into the respective lungs. If it's bilateral, you will place one catheter in the lower lobe of both lungs, and if it's unilateral, then the respective lung, as confirmed on CTPA or with a angiographic imaging in fluoroscopic imaging in cath lab or hybrid theater. Then coming to the ECOS device, on the right-hand side, you can see that is our control unit. That is the ECOS control unit. It is a preset device, and connected to that, there are two what we call CICs. Those are connector interface cables, and the catheters that gets implanted or inserted into the patient then connect to the connector interface cables. And then, of course, the start button is pressed, and there is an ultrasound therapy that is done through the catheters. The catheter consists out of two parts. You have the infusion catheter, which you can see at the top, and then the ultrasound core, which goes inside with a Luer lock device of the infusion catheter. The catheter is a 5.4 French catheter, and currently we have a 106 and a 135 working lengths, meaning the total length of the catheter, depending on your access site, that depends on the working length. Most used is a 106 because from femoral vein you can reach both pulmonary arteries with a 106. Then treatment zones. So treatment zones means where the infusion or the actylase or TPA is being infused, and also where the ultrasound is emitted. So the ultrasound is not emitted throughout the whole catheter. You have a 12, 6, 12, 18, 24, 30, and 40 and 50 centimeter treatment zones. Usually most oftenly used is a 12 centimeter for the treatment of pulmonary embolisms. And currently in South Africa, what we have available is the 12, 18, 24, 30, 40, and 50 centimeters. Mostly the 50 centimeters are used for iliofemoral DVTs, which then covers from the femoral vein all the way up into the IVC. Then coming down to the mechanism of action of ultrasound. So you'll see on the left-hand side, it is basically fibrin strains in a thrombus, with and without ultrasound. So the main focus of ultrasound, it disrupts the fibrin strains, and also with the ultrasound, it creates acoustic streaming of the TPA, which is administered at low doses over the period of treatment, and just to reach the primary points for dissolution of the clot and to dissolve the clot. And then, of course, the unique mechanism of action can improve distal response as well, and to the distal vascular reperfusion as well. And that is our goal, to reperfuse the lung and to take strain off the right heart. Also looking at the mechanism of action just on ultrasound again, you'll see in the bottom left corner, there is a comparison of thrombolysis without and with ultrasound, and you can see that there is quite a vast difference between the penetration of TPA with and without ultrasound. So looking, identical volumes of TPA were infused into identical human plasma cultures. So the total exposure time was 15 minutes that they used, and there was a 17% increase in density and 38% increase in depth of TPA on the ECOS treated side with the ultrasound and the acoustic streaming generated by the ultrasound. I'm going to move over onto some of the clinical trials that we have available for the treatment of pulmonary embolisms. I just want to give a few seconds. Is there any questions regarding the components, the catheter, the machines, or how it works?
We'll handle the questions after the presentation.
Perfect. Right, so we are committed to clinical advancement of pulmonary embolisms. So yeah, you can see some of the trials that have been done. So the Ultima Seattle 2 Optilase, the Real PE, Knockout PE, and then of course the Hypitho, which is currently still ongoing. I'm going to go into a bit more depth then. This is just over time with the respective studies, how the dosage of thrombolytic and the duration of treatment has decreased. So from systemic thrombolysis of 100 milligrams, we are currently, with the latest research and publications, 4 to 12 milligrams over 4 to 8 hours of treatment. So looking at the Ultima trial, the objective was to determine whether fixed dose catheter directed ultrasound accelerated thrombolysis is superior to heparin or anticoagulation alone in reversal of right ventricular dilation. ECOS with 10 milligrams of TPA over 15 hours per lung, treatment per lung. And the other arm was unfractionated heparin, which was administered. The efficacy reduction RV-LV ratio at 24 hours and 90 days, and the systolic RV function, and then, of course, the safety, mortality, major bleeding, minor bleeding, and recurrent PE and death. So looking at ECOS with TPA and, of course, heparin, and then only unfractionated heparin on its own. Reduction in right ventricular RV-LV ratio significant greater over 24 hours. And on the right-hand side, you can see that there was a minor bleeding of 3 patients, death of 1, and 1 bleeding patient with only heparin. But there is a huge difference in the right ventricular function, which has recovered over a period of 24 hours and of 90 days in comparison to heparin or anticoagulation alone. This is also just Ultima, just giving the baseline of the systolic right ventricular function of heparin in comparison to ECOS, and 24 hours and then 90 days. And you can see that the systolic right ventricular function has normalized in 80% of the patients, in comparison to only almost 40% of the patients with anticoagulation alone. Then the Seattle 2 trial objectives was to evaluate ultrasound facilitated catheter directed thrombolysis with low dose for fibrinolysis using ECOS for massive and submassive pulmonary embolisms, and the primary endpoints was the reduction in the right ventricular RV-LV ratio at 48 hours, and then, of course, major bleeding within 72 hours. Then pulmonary hypertension, looking at the pulmonary artery pressure in the Seattle pre-procedure, post-procedure, and at 48 hours, there is a good reduction in the 25% at 48 hours. There's a rapid reduction in the pulmonary hypertension and pulmonary artery obstruction, and with 0 intracranial hemorrhage reported with the use of ECOS. Then just looking, this is just a picture of pre and post of a CTPA that was done, and the blue representing the reperfused pulmonary arteries post-procedure, which you can see after the ECOS was done. Then looking at the Optilase trial, evaluate the optimal duration and dose of TPA with ECOS for intermediate risk PE patients. And there were 4 cohorts in this study. There was a 2, 4, 6, and another 6 hour with the respective treatments or dosages of TPA, as you can see at the bottom of the screen. Then looking at the reduction in right RV-LV from baseline to 48 hours, there's not a big difference in the treatment times and dosage of TPA with ECOS. There is a good reduction in the RV-LV ratio, but it is very similar in the 4 cohorts, which gives good indication, and also gives a good indication to treatment times, as Dr. Modise discussed. Then looking at the knockout registry to understand the impact of Optilase PE study on various USAT protocols being used as standard of care in treatment of acute PE and associated long-term outcomes. Then the key endpoints: thrombolytic dose and infusion duration, the change in RV-LV ratio, and the quality of life of the patients post-treatment. Total thrombolytic dose, you can see it is 4 to 12, 20 to 24, and more than 24. And that was the treatment times. RV-LV ratio reduced 24.6% post-procedure, 1.6% major bleeding within 72 hours. No intracerebral hemorrhage events noted, 1% mortality within 30 days, significant improvement in quality of life. So 69.5% of the patients received less than 20 milligrams, less or equal of 20 milligrams of TPA, and 31% 12 milligrams, equal or less than 12 milligrams. Then looking at the HiPytho study, this is a blinded study by Boston Scientific. It's blinded to us, so I'm just gonna discuss our patient design. It's a multi-centered, multinational, and it is comparing anticoagulation versus ultrasound facilitated catheter directed thrombolysis. Our primary endpoints, what they're going to look at is the PE related mortality, cardiorespiratory decompensation or collapse, PE reoccurrence, and then the HiPytho, the objective to confirm acute PE based on CTPA, and this is just the population, how they work on the population. Elevated risk of early death, hemodynamical collapse indicated by at least 2 of the following new onset clinical criteria: tachycardia with heart rate more than 100, systolic blood pressure of less or equal than 110 millimeters of mercury over at least 15 minutes, respiratory rate of more than 20, or oxygen saturation on pulse oximetry less than 90 at rest while at room air. Right to left ventricular diameter ratio of 1 and more on CTPA, and the serum troponin I and or T levels above the upper limit of normal, which they will use also to monitor the patients for clinical deterioration or improvement. As Dr. Modise discussed, the new score. This is just the colorful one, but it is exactly the same. Then looking at the real PE, we were very fortunate to publish the data of real PE. Dr. Modise did discuss also the competitive products in the market. This is looking at FlowTriever, which is a mechanical thrombectomy device. And this was done on real-time data that they used 83 million patients and looked at the pulmonary embolism patients, which the patients were treated with ECOS or FlowTriever, and comparing the two. So looking at in-hospital death, major bleeding, intracranial hemorrhage, and ischemic stroke, 30-day readmission, and length of stay in hospital. And looking at also the real PE, there's a unique real-time data from 83 million patients as discussed. All consecutive patients diagnosed with pulmonary embolisms treated with either ECOS or FlowTriever. And definitions were statistically greater with FlowTriever, so major bleeding rates were statistically higher with the FlowTriever. Intracranial hemorrhage rates were greater with FlowTriever, and the length of stay in hospital, mortality, and 30-day readmission trend in favor of ECOS. Then also just some interesting facts on systemic thrombolysis. In randomized trials, systemic thrombolysis is associated with 11.5% risk of major bleeding and 2% risk of intracranial hemorrhage. In clinical practice, systemic thrombolysis associated with 19.2% risk of major bleeding and 5% risk of intracranial hemorrhage. And also very important, in clinical practice, systemic thrombolysis is withheld in up to 2/3 of patients with high risk or massive pulmonary embolisms due to either contraindications or the patients not fitting the criteria for systemic lysis. This is just the society recommendations, which you can all see in the intermediate high risk from the American Heart Association, Interventional Radiology, European Society of Cardiology, the PERT Consortium, and the American Society of Hematology. All of them low risk advising anticoagulation alone, intermediate high risk. Most of them advise catheter directed thrombolysis, or then in this case, what we are discussing, ECOS can be considered. And then in high risk, according to the European Society of Cardiology, is the indication for CDT, is if there's any contraindications for systemic thrombolysis, or then failure of the treatment of systemic thrombolysis. And that is the end of my slideshow. I'm not going to keep you all busy for much longer. Once again, Dr. Modise, everybody from Clinix Group, thank you very much for the opportunity to be able to present this therapy. And if there are any questions regarding the clinical trials, literature, anything, everybody, you can relay your questions to Dr. Modise. He's got my contact details, and I'll be happy to share and answer questions if need be.
Thank you very much, Francois, and thanks a lot, Dr. Modise, for the wonderful presentations that you co-shared as we talked about this important subject. I know Dr. Modise is quite passionate about this and has been waiting to do this presentation. It's quite exciting for him to be on this platform tonight. Just two questions for you, from me, Dr. Modise. You spoke about a team. I'm not sure if you told us where the members of the team that needs to be doing this kind of procedure. And secondly, patients who present at any of the facilities where maybe they do the CTPA and they find that the patient is a candidate for this procedure. If they do not, because you need to have a cath lab or a hybrid unit for you to do this procedure. But if you don't have such a unit, is the time limit as to when this patient can be transferred to your center?
Thank you very much, Dr. Bila, for your question. So just to give a bit of background, so I've started this project last year to go undergo training of how to do this procedure. And before we started doing the cases at Lesedi, I developed a protocol which I've formulated and discussed, and formulated a team. So the team at the moment include the cardiothoracic surgeon in the Lesedi group, Dr. Ngujani. I've got anesthetist as well, Dr. Sebesho, the cardiologist as well. Dr. Maduna take care of our patients in ICU. So it's quite a well-formulated team, which obviously needs a bit of tweaking and be able to discuss patients as they come through. So just to give a bit of history as well, so far we have done 8 patients in our setting. All the patients were intermediate risk patients. We did them at the cath lab, the same cath lab that I use for other procedures. So we did 6 pulmonary embolism patients and 2 patients with severe DVT at the moment. So what happens is that these patients, how we pick them up is patients will come through casualty. And most of the time, the casualty officer can request a CTPA. And what we have done in our radiology group is that all the patients that are having positive or main pulmonary vessel thrombi, we communicate amongst ourselves and we relay. Like normally what we do is if there's positive PE, we update a referring physician or we ask casualty who's a referring doctor, and we communicate or give feedback to that referring physician. So all those patients that are presenting with high or with massive or submassive thrombi, what we do is we then alert the referring physician, and then I discuss the clinical scenario with the referring physician, and we do the investigation as I listed on my presentation. We do cardiac echo, we do the cardiac markers, and we do the bloods and the vitals of the patient. So it's a collaboration between the whole team members to be able to decide which patients are good candidates and which patients are not good candidates. So we're still developing the pathway of actually how to perfect it in a way that we don't miss patients along the way. But at the moment, that's sort of the sort of structure that we have. It still needs a lot of work because the project started beginning of this year. Like I said, we have done 8 patients. And we still, the bigger the team, the better, because I mean, with high-risk patients, we'll have to have a call system whereby one of the team members can come out, the ones that are able to do the procedure. So the patients are monitored all the patients are monitored in ICU. So post catheter insertion, patients are transferred to ICU. We have trained the sisters in ICU on how to monitor the machine that Francois has showed you. So the patient stay on the machine with infusion and ultrasound activation for a minimum of 6 hours. And the sisters, we have trained them on how to monitor the machine and which relevant vitals to take. And the patient, then the lines are removed post-treatment.
Okay. It's quite exciting. I see there's a happy physician who says a patient did well after getting this procedure.
Yeah,
so you do have collaboration. You don't only get referrals from within Dr. SK Mmusakgotla, but even outside.
Yes, we did one patient from Naledi, one patient from Dobsonville, and one patient from Butselong. So at the moment, we in good communications with the physicians around the Clinix group in our facility. So it's a work in progress, but it started very well. I mean, the first patient, I remember him very well when after he came in with massive distress. And I remember in 2 days, Dr. Maduna was discharging the guy. The guy was walking home. I met him in the corridor. He's like, I'm going home now. And he was a very ill patient on admission.
Okay, thank you very much. I hear in your team, you've not mentioned neurosurgeons. Any in a future collaboration with neurosurgeons for patients who may come with some intervention that surgeons need to work with you?
It sounds like you're more on the stroke, Dr. Bila.
Yeah.
Yeah, so we're not there yet, but hopefully in the future we'll have. For me, like I started my presentation, I mean, PE is the third most common issue in in medicine. So I mean, in the future, if you can have this project running like an oil machine, whereby patients from all the 4 centers, everyone is aware of this treatment, I think the next step will be to collaborate with the neurosurgeon and start a stroke clinic in the city.
Okay, yeah, it's a challenge.
Yeah.
Okay, colleagues, anyone who's got a question, please don't hesitate to unmute yourself or post. I don't see any questions in the chat group, chat box. Anyone, just people are quite excited about this new intervention that we've started. Dr. SK Mmusakgotla, it's establishing good center, and I think as you center of excellence that you are starting with your team there. Yeah, in the absence of further questions, or maybe it's something new, people are still pondering on it and not knowing. Yeah, question about how can you access the slides? Are you keen on doing that? I know that we've always had to deal with this question. Are your slides available, and can we share them with the colleagues who are here, as one of the colleagues wants to know?
I don't have a problem with that.
Okay, so I think what we'll do, we'll share them with Kamo, and then we'll share with everyone who was registered. I'm going to ask Professor Jeff Wing, who's our physician consultant on the risk committee and an endocrinologist, to make the closing remarks. Prof. Wing.
Thanks, Dr. Bila. Congratulations, Dr. Modise, Mr. van Staden. It was a great review, great learning experience. Nice to mix clinical data with technical data. So congratulations to both of you for this excellent presentation. Looking at it from a physician point of view, I think this sort of strategy is going to obviously change the way medicine is practiced. And just to comment on what Dr. Bila was trying to allude to, perhaps, is that maybe going forward, there should be an integrated unit that would deal with thrombotic strokes, coronaries, peripheral vascular disease, so an endovascular surgeon, and obviously, your team that would deal with acute pulmonary emboli. So I think there would be some value in the strategy in terms of what academic medicine, particularly within the Clinix group, can achieve in the near future. So perhaps, Dr. Bila, you alluded to an acute stroke unit, but I would suggest you should extend this more widely. I think also looking at where gaps may occur, good lectures like this often lend to more questions. So a good paper answers, provides a solution, but in turn asks many other questions. And so obviously you need to involve a pulmonologist for issues that may happen downstream. I'm talking about chronic pulmonary artery hypertension. And I wonder if this is a question, perhaps I should have asked it, but going down the line, is there any place to look at preventing chronic arterial hypertension? So cardiology went through the same experience where they reperfuse coronary arteries, perhaps the arteries smaller, anatomically very different, but then the advent of more modern stents and drug-eluting stents to prevent arterial thrombosis after the artery was rendered patent. So again, this is just questions, searching questions which a good lecture stimulated in my own brain, even if it's 7 o'clock. So I thank you again, both of you, for this excellent interpretation of clinical treatment and the technical backup and expertise that's required. So thank you very much.
Thank you, Prof.
Thanks a lot. So you've got a lot of, you presented, but we've given you some homework, Dr. Modise.
Thank you. Thank you for the homework.
Yeah, but I think it's Prof. Wing, academic paper to follow and more collaborative work and getting other disciplines involved in this unit that we talk about. So building up a big center at Dr. SK that we can be proud of in some years to come. So I just want to thank you for making yourself available to this presentation, and also to Francois from Boston Scientific and to Kamo. I mean, before Kamo, the colleagues who've logged in tonight, thank you very much for being here. It's good to see most of you coming back every week for these presentations, and we hope to see you again next week as we continue with our presentations, primarily from within our clinics, hospitals. These are the team colleagues who will be presenting this whole month. And just want to thank Kamo and Anza and for the good work that you're doing in the background, and also the marketing team, and also management executive committee clinics. We hope to see you again next week, and good night.
Thank you.